it's certainly for me a pleasure to introduce Dr. Evans. He started his career as an attending physician in internal medicine in Boston in women and oh my goodness, hold on. That is a name that has always given me a hard time trying to pronounce. So just please bear with me. In Brigham and Women. So I hope I got it right. After that, Dr. Evans joined the WHO as Assistant Director General. He also went ahead and was the dean of the James P. Grant School of Public Health in Dhaka, in Bangladesh, the Bragg School of Public Health in that country. And after that, he joined the World Bank as the person responsible for health and nutrition and population in the bank. And more recently, he joined in the McGill as the inaugural director and associate dean of the School of Population and Global Health. And he was also named the executive director of Canada's COVID Immunity Task Force in April 2020. So Dr. Evans has a sound, diverse, and protracted experience in global health, and we're so elated. We're elated he's here today with us, sharing his experiences and wisdom. So thank you, Tim.
Great. So thanks very much, Sonia, Rena, and Juan Carlos for having me. It's a great opportunity for me to torture you with a few ideas and thoughts. And so hopefully for those of you in need of a midday rest, my PowerPoint slides will give you reason for bilateral ptosis, and I'll ring the bell when I finish. Otherwise, I apologize in advance for my presentation. I'm going to just switch now. I'm going to share the screen, I believe, and bring up my slide. Let me know if you can see. Can you see that first slide there, everybody? It's called Universities and UHC, Laggards or Leaders. Universal health coverage is UHC. So this is, I'll talk very briefly about how well we're doing by the SDGs. The Sustainable Development Goals are supposed to achieve universal health coverage by 2030. And I'll provide a perspective from Canada. I say that because some people have delusions about universal health care and universal health coverage in Canada. And I'm a big believer we should always be sensitive to our own backyard. And that's my backyard at the moment. And then I'll just move into the role of universities in UHC, in part because I see your efforts at organizing this symposium and the whole surge effort as evidence of academic leadership where it's greatly needed. So congratulations in advance. And I'll talk about 3 dimensions of what I think are university agendas on this front, which is the generation of knowledge, the development of know-how, which are skilled professionals to work and lead health systems. And then I'll finish with a few role models or examples of things that I think have made a difference or may make a difference in this area. So we should be finished by 6 p.m. your time. So for those of you in need of an afternoon siesta, off you go. So this is realizing the right to health, and this is really essentially what universal health coverage is all about. It is really about providing benefits in terms of services that are needed in the population. It's also very sensitive to the way in which people access the system financially. And so contributions that are prepaid in pool and sensitive to differential ability to pay are the way in which the system works, with a particular focus on the neediest. The reports that are made regularly to the United Nations General Assembly on progress, usually every 2 years, suggest that we still have a long way to go. We may have lost some ground in the context of the pandemic, but essentially about half of the world's population lack access to basic health services. And very unfortunately, about 100 million people are impoverished yearly due to the way in which they have to pay for health services, which is essentially paying at the time that they're sick. It's like kicking someone when they're down. And so that's a lot of people that are actually made worse off through their interactions with the health system. This is a faceplate from the Lancet from over a decade ago, saying academic medicine must take more responsibility for global health. And I'm a big believer that that's not only a responsibility, I think it's a huge opportunity as well. Question is whether we're laggards and getting pulled to this slowly, or whether we're rocketing ahead as leaders. And I'll let you guys decide which side of technology you want to be on. But I do think it's an important thing for academic institutions to be thinking about, because they do have a leadership role, whether they like to recognize it or not. Let me switch to my own backyard. This is one of our maverick politicians in the middle here with the glasses, the short fellow in the middle. His name was Tommy Douglas. He was the premier of essentially one of our provinces in Canada. We have 10 provinces and 3 territories, in contrast to your 50 states in the United States. So Tommy would have been perhaps, the governor of Utah. And he, in the 1950s, was very concerned that people had to sell the farm in order to get care for their sick family members. And so he felt strongly that no boy or girl should have to depend either for his or her leg or life upon the ability of their parents to raise enough money to bring a first-class surgeon to the bedside. And in 1962, he introduced the Saskatchewan Medicare Act, and that prompted all of the members of the Saskatchewan Medical Association to go on strike for a year. And they decided they wouldn't come back to work until the Saskatchewan Medicare Act had been repealed. And after a year of negotiation, they came back to work with the Medicare Act in place, but an agreement that physicians would be paid on a fee-for-service basis. That model of provincial health insurance spread across Canada over the next 5 to 6 years, and by the end of the 1960s, every constituency in Canada had a provincially based universal health insurance system, which provided, in principle, universal coverage. At my own institution, McGill, this fellow on the bicycle who was practicing health promotion in the 1960s, the first chair of the Department of Epidemiology at McGill, he got an NIH grant. And it was very interesting. The Americans were very interested in understanding the impact of Medicare on the health system. And so this study that was undertaken by Corbett McDonald and colleagues, published in the New England Journal in the early 70s, showed that in fact the advent of Medicare in Canada, provincial health insurance, really had a pro-equity perspective. which is families from lower incomes were able to consult medical doctors more frequently following the introduction of this Medicare. Despite those promising beginnings, we still have a lot of challenges in Canada, and I would want to make sure that there's no exceptionalism in the Canadian perspective, even though from the US perspective, we might look a little better off. The reality is we have all sorts of challenges, and here's just one of them. One of our national newspapers was looking at the distribution of psychiatrists and showing that there are massive distributional inequities in terms of access to psychiatrists across our country, with millions of people underserved and all sorts of problems in terms of fair distribution of the workforce. This is the picture across Canada, and you can see these different colors in different parts of our country give an indication of the extent to which you have clustering and areas in the lighter colors with massive underrepresentation of psychiatrists, and really tip of the iceberg in terms of the inequities in accessing good mental health care. As a good colleague of mine from the WHO used to say, he's no longer there, he's retired to greater things. When it comes to mental health, all countries are developing, and Canada in that context is no exception whatsoever. I want to just spend a minute on another part of the world, which is Kenya, where in fact you can see a very different model of universal health coverage taking root, and one that's been spearheaded by something called AMPATH, the academic model providing access to healthcare, which has a very strong link with Indiana University. It grew up around the HIV access to antiretroviral therapy revolution in the about 20 years ago, and has evolved to become an incredibly interesting collaboration over the long term with an academic health center in Western Kenya. So on the basis of that, let's look at the knowledge for UHC. And I'm going to be a little bit biographical here in terms of my own experience, but given that I've been in the global health trenches for a while, we've been trying to make sure that UHC isn't just empty rhetoric, but that it actually has a knowledge base behind it. So the first part of this is about systems assessment. And this is a picture of me when I used to work at WHO. And whenever I had a problem, I would push the books on my desk in one direction. And little did I know what that would end up achieving. But this cartoon is really just an indication of the unintended consequences of systems change, and led us, when I was at WHO, to develop something called the WHO Health Systems Framework. And the reason this is important is we tried to take the view, or take away the view that health systems were a black box or a black hole, and really sort of enlighten them by identifying core building blocks that were discrete areas where you could focus and understand dimensions of the system that were critical to focus on, and how they came together and were related to the overall goals and performance of the health system. And as you can see, the health workforce is one critical building block of the health system, and I'll come back to that later. With a view to improving knowledge for UHC, we created a first global symposium on health systems research in 2010. And this was really on the basis of meetings with ministers of health and a recognition that we needed to nudge research in the direction of research on health systems because there was an underinvestment. Lots of research on biomedicine, lots of reasonable amount of research on epi and clinical epidemiology, almost no research on health systems. And so we said, let's focus on universal health coverage as a systems a performance goal and objective, and see how can we marshal research to enhance or accelerate progress towards universal health coverage. And so this symposium tried to come up with a priority research agenda and fostered collaboration in learning communities. It looked at the definitional, conceptual, the tools, the measurement issues related to advancing the field of health systems research, and looked at ways in which one could invest to strengthen that research across countries. When you look at the impact of that, this slide would make you think that we did very well. If publications on universal health coverage were a function of that symposium, then this increase in the number of publications on UHC, universal health coverage, in this millennia, particularly in the last 10 years, might suggest that this symposium had an important effect. However, when you look at it in perspective and compare it to the timeline on trends in publications in other areas, for example, HIV, you can see that the gray line here the slope is far steeper than the line for publications on universal health coverage, suggesting that although it's a move in the right direction, there's still a long way to go. If you look at the institutional knowledge leadership around UHC, there are some indications of it, but it's still very nascent. You don't see many centers of excellence. When I was in Bangladesh, we created a center of excellence for health systems and universal health coverage. The National Institute of Public Health in Mexico has a major focus on health reforms for universal health coverage. And KPMG, one of the big accounting firms, has a center for universal health coverage. But when you look across schools of public health and you look across academic health systems more generally, you don't see dedicated concerted scholarship and academic activity in this area. We try to foster joint learning, practitioner-to-practitioner networks, and we created a joint learning network for universal health coverage. And this network continues today, and it's actually a tremendously vital network of people who are on the front lines, who face common questions and challenges and find solidarity in drawing on experience from other contexts, as well as opportunity for designing common protocols to understand relative how to overcome bottlenecks and perhaps new models of care that can inform directions in their respective backyards. There's been lots of success despite the lack of scholarship. This was the Lancet Commission on Bangladesh, and it showed really breakthroughs in improvement, for example, around immunization coverage and a real pro-equity trend over time. And the provocative title here was improved equity and immunization coverage by asset quintile in Bangladesh. Are we breaking the inverse care law? And inverse care law is in quotes because it refers to the famous article written by Julian Tudor Hart in the Lancet in 1971, in which he said that even in the context of the National Health Service of the United Kingdom, you saw trends towards inverse care, meaning those people with the least resources and the greatest health needs who are least likely to access the services of the national health system in the UK. And he described that paradoxical or unintended consequence as the inverse care law. In other parts of the world, for example, Chile, you can see that effective coverage of interventions for NCDs, non-communicable diseases, lag well behind those that were identified as priorities for the MDGs. The darker blue here looks at the effective coverage of NCD interventions and shows very, very poor effective coverage. And the measure of effective coverage really drawing on that concept of effective coverage that looks at all sorts of bottlenecks to access, affordability, acceptability in terms of accessing interventions that are known to be quite effective, at least in clinical trials. When you get beyond the individual care access and think about public health, then the universal health coverage becomes even more daunting. And the knowledge on how we get effective coverage of public health surveillance, for example, is really lacking in many places. This is the village that was host to the first, the sentinel case of Ebola in December 2013. And literally it was a village off the tracks with no health center and no contact to formal health services. And it wasn't until March, 3 months later, when the outbreak had crossed rivers and borders and was firmly rooted in 3 different countries, that there was the first formal diagnosis of Ebola virus disease. And so you can see the consequences of having shortfalls in universal coverage for core and critical public health functions. And of course, this has been followed up by COVID. These are the early days in Wuhan, and we all know what an incredible roller coaster the last 14 months have been in the context of the pandemic. There's a whole frontier of knowledge that is in front of us and exciting, and it's really sort of the promise of harnessing the digital revolution in terms of how it might contribute to UHC. On the left here, you have drones that drop payloads of life-saving commodities, either blood or vaccines, to remote areas. And in Rwanda and now Ghana, this company called Zipline has basically completely revitalized the old distribution chains, the supply chains, and with these drones has provided timely, quality delivery of life-saving products. And then on the right here, the move to robotization and the use of robots in terms of triage, in this case, in the context of China, but also for managing complexity related to symptom complexes and others. Machine learning is really something that is ahead of us and potentially transformative. But it also, the knowledge agenda really relates to some basics and ones related to the way systems perform or don't perform. And I'll come back, as I said earlier, to one of the defining dimensions of UHC, which is progressive payment. And we really need to look at ways to transform what I call pay when you're sick financing. There isn't a shred of evidence that supports this as either efficient or equitable. In fact, it is the most inequitable and inefficient form of financing, yet it prevails in way too many countries as the primary system for financing access to care. It consumes about $600 billion per year and impoverishes 100 million people. Its growth is faster than public sector spending on health. And if you could simply harness 25% of that expenditure annually, that would be $150 billion per year extra for universal health coverage. And that's about 5 times development assistance for health. So this is a huge frontier for knowledge generation, and one where we really need to think about going beyond old systems run by white men, and the Bismarck system, which is the social health insurance system, which is most prevalent in the United States, the Beveridge system, which is the tax-based finance system, which you see in the UK, but also Canada. And Benjamin's is the way I put the paying out of pocket when you're sick. So all of these systems need to be rethought in the context of the 21st century and what makes most sense for financing equitable access to care at scale in any setting. But it's not just that with what we do with the care system. We've realized that social inequalities emerge and redefine themselves time and time again, certainly as we've seen in the context of this pandemic. And so when I was at WHO, we catalyzed this Commission on Social Determinants of Health, and the agenda there related to knowledge to diminish gaps in health is a tremendously important agenda, and one where academic health centers have particular responsibility. And so when we look at this, as we did after 30 years of primary health care, the agenda to achieve health for all by the year 2000, which wasn't achieved, but when we wrote the World Health Report in 2008 on the 30th anniversary of Alma Ata, we recommended 4 types of reform in terms of universal coverage, leadership, service delivery, and public policy. And in that report, as one of the big public policy reforms, we noted that no other $5 trillion economic sector would be happy with so little investment in research related to its core agenda. And this was really addressing the skew in investment related to research that is going to address improvement in the overall behavior and performance of the health system. And so this is an area, again, where I think academic health centers need to be at the vanguard, pushing for more research on the performance of systems and not just research on new medicines or research on population level epidemiology. We have, I think, perhaps the biggest challenge now ahead of us in terms of universal coverage in the context of the pandemic. The power of global science has delivered us vaccines faster than anyone thought possible. 4 vaccines approved within a year makes the former fastest time to get a vaccine, one vaccine in 4 years, really evidence of just what's been achieved, which is remarkable. I think the real question now is, can we have similar coverage related to vaccines and their delivery? And so can we achieve universal coverage of COVID-19 vaccines, and when? Because we know the timing is going to make a difference. So from the knowledge agenda, let me now just move briefly into the know-how for UHC. And this really relates to the training function of academic health centers. When I was at the World Health Organization in 2006, we issued a report called Working Together for Health, And that report identified a critical shortage of health workers in 57 countries and identified a need for at least 4.3 million more health workers to provide essential interventions that would help, at that time, achieve the Millennium Development Goals. When we updated this by looking at the SDGs and forecasting health worker need and labor market demand, we identified similarly very large deficits based on both need and demand analysis across different countries and different income groups, and very high rates of growth in supply that would be required to meet either the need or market demand for those health workers. And in the absence of any efforts to secure that growth in the health workforce, then you have continued shortages and maldistribution of health workers, both within and across countries. This is what that distribution looked like across regions of the WHO in 2006. You could see Africa that hosted 25% of the world's global burden of disease, with the smallest share of the health workforce and the lowest per capita spending, whereas the Americas, with the only 10% of the global burden of disease, had the largest share of the global workforce and also the highest per capita income. So these are issues where systems dynamics tell you very simply that if we're expecting, or if one's interested in a transformation of health opportunity, say in Africa or Southeast Asia or the Eastern Mediterranean, it's not going to help. It's not going to happen without a major investment in scaling up the health workforce. However, the health workforce is not something that has independent demographics. It relates in large part to what's happening in fertility overall and the size of the cohorts that are moving through the population. And this graph here just shows that declining fertility rates are not just a problem or not just found in so-called developed economies. You can see across many middle-income countries that the time trend between 1970 and 2020 are dramatic declines in fertility. And with that, you find that with great increases in need for healthcare workers and decreasing cohorts of people entering education and university, that there will be increasing gaps in the number of health workers being produced. And in that setting, countries go to the global markets to fill the shortfalls. Africa is a very interesting case in point in terms of understanding rapid demographic and epidemiologic and economic change, something I call epidemionomics. These are faceplates of The Economist. In the turn of the millennium was the hopeless continent. A few years later, Africa was rising. A few years later, it's aspiring, and now it's taking off. And these progressive trajectories of what the continental GDP will look like make it clear that this continent is going to look very, very different by 2035 than it even does in 2021. But very importantly, it will probably be home to half of the world's population. And insofar as there are health worker shortages in many other countries, the likelihood that Africans will be an important source of migrant workforce for health is very, very high. When you look at the state of education, I like alliterations, and these are some of the things that informed a Commission on Health Professionals for a New Century that we looked at. And student skews and suffering in many places in time that you need increased enrollments, they're stagnating. discouraged by high fees and very high rates of attrition, even if students enter into health professional training. The pedagogy is prehistoric, outdated curricular content, teaching methods and materials characterizes many settings. Faculty are very hard to sustain, poorly paid, not well supported, and very poor career prospects. Lots of institutional inadequacies. There are too few health professional training institutions relative to need. They're mostly found in urban areas. They're mostly focused clinically, very to the detriment of public health, and often with crumbling infrastructures. And there's massive investment in sufficiency and inefficiency, as well as absent functions for core things like accreditation. So this is the crisis things. It's obviously not quite so black and white, but when you drill down and look at the state of health professional training within countries, this sort of diagnosis is not often an exaggeration. In Bangladesh, where I worked for a number of years, we saw a huge urban bias in the location of health professional education institutions. Dhaka on the left, the capital city, 20 million people. You can see the vast majority of health professional institutions were concentrated there. And Barisal, Rangpur, Mymensingh, more rural areas, very, very scant coverage. And so these are structural inequities that are not only found in Bangladesh, but certainly there. And then the other thing that you see is this trend of growing privatization. And so public sector stagnates in their ability to support and grow health professional institutions, and the non-governmental here in the red, you can see growing over time, particularly since the year 2000 in Bangladesh, an indication that most of the change and growth in health professional training has taken place through the private sector. This is seen in other countries, India and Brazil as well, where private approaches to health professional training are ones that are explaining the lion's share of growth more recently. And the question here is, the issue here is not that private sector is bad. The issue is, how do you make sure that you've got standards of education, access, and quality that are going to ensure you've got the workforce you need for the future. So in the context of a sense of a crisis, Churchill said, never let a good one go to waste. And I think this faceplate from Time is one that gave me a little bit of inspiration. It's one of the silver linings from the Ebola crisis in West Africa on the value of the health worker. And it really begins by recognizing that people, in fact, are your most important resource in any health system. Not money, people. And I think this then gives some sense of why one has to pay a lot of attention to how you nurture the numbers and the qualities and the conditions for people to really make the contribution that they can as the most important resource in a health system. We tried to put this in the context of the demand and supply systems dynamic framework around UHC for the World Innovation Summit on Health a few years ago. And we really looked at the demand arising from health systems and the supply associated with health workers' education, and looked at the situation where UHC was not guiding things, which led to skews in demands, urbanization, payment based on volume, not quality, access to care based on patients' ability to pay, and then neglect of the supply side, meaning you had a weak pool of eligible students, too few and a narrow scope of education institutions, curricula that were increasingly focused on marketable skills, not necessarily needs-based skills, and accreditation and licensing functions as barriers to entry, not really as promoting quality, and all of that resulting in performance both in the supply and demand of the system, which was leading to huge imbalances, inequities, and working away rather than towards universal health coverage. We tried to say, well, then what would it look like if the system was functioning in a way which was going to move both the supply from the education side and the demand of health systems more towards universal health coverage. And on the supply side, this meant building a stronger pool of eligible students with attention to diversity, a much greater scale and scope of education institutions, thinking about career opportunities across the full career, and orienting curricula to be competency-based, and doing that hand in glove with reforms of the health system that were more balanced across primary care and curative and health prevention, making sure that jobs were located much closer to the population needs, and that there were payment systems that were incentivizing team-based care. So this was an effort to really try to rethink the dynamics of the system from a policy perspective to get a better interaction of supply of education and the function of health systems so that it would be working towards universal health coverage. Another effort I was involved in related to a Lancet commission entitled Health Professionals for a New Century. And here the idea was transforming education to strengthen health systems. And we issued this report in 2010. And it basically, looking back 2010 to 1910 with the publication of the Flexner report on medical education, it identified generational changes or generational education reform, starting with Flexner and the scientific curriculum, which was university-based in the early part of the 20th century. Mid-century, the introduction of problem-based learning at McMaster University in Canada, and the evolution to academic health centers. And then finally, what the commission was advocating as the next generation was competency-driven local global health education systems. One of the key recommendations coming from that report related to types of learning. And when we reviewed curricula in health professional settings, we found that almost all of them worked quite well on the first level of learning, which was called informative. And these are specific technical skills that define experts. And in general, most health professional education institutions did a pretty good job on that front. But on the other two levels of learning, around formative skills and transformative competencies, which were associated with values and leadership attributes, we found that there was much less curricular competence or institutional competence on those fronts, and identified those as important priorities in terms of an agenda of reform for education in the 21st century. So let me translate this a little bit in terms of some of my own experience, where I had the privilege of being the dean of the James P. Grant School of Public Health in Bangladesh, where our mission statement was knowledge and know-how for health equity. And this was really the idea that public health students needed to learn outside the classroom, first and foremost in the community, and from there guide their education in terms of the competencies they needed to understand and address public health problems. While I was there, somebody brought to my attention the website at the Harvard School of Public Health. I'm not sure where that is. I think it might be in Boston. But on the Harvard website, there was a picture of some educational activity in Bangladesh. And somebody said to me, that's actually a picture from the James P. Grant School of Public Health in Bangladesh. It has nothing to do with Harvard. And in fact, we found out that Harvard had somehow wanted to have this as sort of what they wanted to portray to prospective students in terms of coming to the school. So this we found when I was in Bangladesh, the greatest form of compliment, and we paraded this around for a long time as evidence that our school had hit the mainstream. It was all a function of this leader, Sir Fazl Abid, who departed us unfortunately about a year ago. But he was a big believer that most programs remain small and beautiful and never impactful. And he says, when you have millions of people in poverty, you can't remain small and beautiful. You have to be effective and large, even if large means ugly, although he didn't think large necessarily meant ugly. And Sir Fazl was really a pioneer of innovation at scale, not simply with respect to poverty, but also with respect to health. And much of what he pioneered, never having been a formal health professional himself, has been some of the greatest leadership for health of people, not only in Bangladesh, but in many other countries where BRAC works. Just one example on this front, we were looking at trends in maternal health care when I was working there, and we saw that facility delivery rates, which were being recommended for all pregnant mothers, were going up slowly, and so too was skilled attendance at birth. But what we found very concerningly in the blue line was that so too were rates of C-section. And when we looked at the percentage of C-sections taking place in facilities, it was almost 2/3 of deliveries. And this was really overcare and reflected a massive absence of skilled midwives. And so with the Prime Minister of Bangladesh and others, we were part of a campaign to train more midwives in Bangladesh. And we came up with an innovative model, which was really to not bring everybody to Dhaka, but to decentralize training such that you trained women in midwifery from the communities and parts of the country where they were resident. And this led to a hub and spoke model for training community-based midwives, which was facilitated by BRAC University and our school, but which was in partnership with a number of the care providing NGOs and government facilities that were based in various parts of the country. And all the students were selected and supported on site from those regions. Another dimension of the health professional training, which I think is gaining more ground, but continues to need attention, are really the frontline workers. And it's this recognition of this picture here where a woman assisted with a smart device in her hand is actually bringing care to the community rather than having that individual spend a ton of time waiting in line and going to a clinic. And I think this frontline mode of interaction is really where we're going to see things in the future. Another role model here, the University of Global Health Equity, Agnes Binagwaho, former Minister of Health in Rwanda, has really sort of walked the talk on changing the paradigm for health professional training. She's created a school of medicine and a great school of public health in a rural area of Rwanda, and is really looking at how education can be oriented to meet the needs of the poor in rural areas, and not just in Rwanda, but as part of a a network of schools of global health equity that are part of the University of Global Health Equity in multiple countries. Just turning a little bit to my own efforts in Bangladesh. When I was there, I was confronted by a number of young women who complained to me that they were unable to access doctoral training in public health because it was very difficult for them to find the conditions that allowed them to spend 3 years outside of Bangladesh. We had no doctoral training in Bangladesh. And for them to find 3 years or more on their own at Hopkins or elsewhere was really not something that was compatible with their life course. And so what we did is we created a sandwich training program and got support from USAID. And I ran into this woman about 14 months ago at a symposium on women's health, global women's leaders in global health in Rwanda. And this was one of the students that we supported, now a doctor, PhD in public health, and evidence that when you put money in this cohort, there are incredibly rich returns in the near to medium term. I'll finish by giving another story. This was one of my MPH students from Bangladesh, a nurse who was specialized in emergency work in emergency settings. She was the second in command in the Ebola virus outbreak in Liberia. And she was somebody who, when I was in Bangladesh, was very active as a student in trying to understand the global health architecture. And to facilitate that, we did a simulation of a World Health Assembly Executive Board. And Miata, this person, was a minister of health from one of the countries, as were all the other students, and they debated resolutions. And when we were reviewing the program, as we did every year at the end of the year, one of our external reviewers said, well, why would you waste anybody's time teaching them about the World Health Organization and its executive committee and its assembly and things? That's all nonsense. It has nothing to do with what happens in countries. Well, this is what happened 4 short years later. Miata was addressing assembly, the World Health Assembly, providing her account of the Ebola crisis in Liberia, and had 200 member states listening to her description of how the country attempted to manage the crisis. And as somebody who's been associated with her education, it was one of those proud moments that you have where you feel that, in fact, this is why you teach people about global health, because their leadership may be and is likely to be an important part of that community in ways that you would never expect. So with that, thank you very much for your attention, and I look forward to any questions you may have.
Oh, thank you very much for this illuminating presentation. It was good to see the connection between the historical movement towards UHC and finalizing with the integration of the involvement of women leaders in articulating global health and making a change for good in that setting. We do have questions for you from different participants, and something that came out in your presentation when you were articulating that ascendance of C-sections in Bangladesh has also another side of the story, and I wanted to bring this to our polemic in this field. We saw that in the last 50 years, Bangladesh made an important reduction in maternal mortality that was much faster than that one of Sweden's in a similar time frame. And the private sector played a major role in providing access to healthcare services, and I see I myself suffered a bit on the C-section thing, and just because we found that in the institution that we were advancing and supporting, and at the same time that the MMR survey of 2010 was a big surprise for everyone because we never expected Bangladesh to have such a major reduction in maternal mortality. So, so how would you harness the power of the private sector in making this important transformation and involving, of course, academic health centers in that activity, and trying precisely to make what is certainly a good outcome a better outcome?
Great. Well, thanks, Juan Carlos, for that question. I think you've just introduced my next 60 slides. No, it's a huge issue. It's massively important. Let me say just a few things. One is the academic setting needs to understand that what happens in the private sector and the informal private sector is enormously important. When I was in Bangladesh, we went to a village. We saw a woman who was in her third trimester. I asked her a question, who are you going to deliver with, or where are you going to deliver? She said at her home. I said, who are you going to deliver with? Fully expecting her to talk about a midwife or a traditional birth attendant. She said, no, I'm delivering with my pharmacist. And I said, well, what do you mean? And she said, my pharmacist is going to put the IV in and then push the tocolytic or the agent, which is to induce uterine contractions. And my eyes sort of opened up like this. And I said, well, where's the pharmacist? And she said, there, 20 meters away. And it was an indication that we went and visited the pharmacist, and he had beautiful IV equipment. He knew aseptic technique, and he had a good supply of Pitocin. Now, whether or not he was giving that at the right time, fourth stage of labor or before, don't know, and nobody was studying it. But it was indication of a cadre, the village pharmacist, totally self-employed, dependent on good relations and trust with the community for his livelihood or her livelihood and things, who was completely in front, out in front here, and completely dissociated from whatever was coming out of the public health system or the government health system. And so I think I'm just using that as an example of a huge blind spot. If you don't open your eyes to that reality, then you miss all of the opportunities as well as the threats associated with not understanding what's happening. So I think if one looks at that, then all of a sudden you say the 20,000 or 50,000 village pharmacists in Bangladesh are a huge resource. How do you work with them? How do you give them more support? How do you understand their interactions on the front line such that they're going to be, more effective agents for the community's health? So I think we need to pay attention, study them, and work with them and push through barriers so that they're not seen as marginal and illegitimate, but increasingly mainstream and legitimate.
Thank you very much. We do have a very interesting questions, I think, from the audience. One is from Daniel Long, who you know. He's asking, how do non-health system-focused academics, like epidemiologists, immunologists, efficiently engage in the promotion of better health systems work in the countries in which they collaborate?
It's a great question, and if as a big advocate of systems, the worst thing for systems is if you left it only to people who think they're systems experts. That would be a massive tragedy. First of all, there aren't enough systems experts, and second, they know nothing about other dimensions of health, like surgeons or epidemiologists or others, other professionals who bring huge insight and clarity on the nature of specific problems. So interdisciplinary approaches to systems are critical. In that context, clinicians, depth specialists in various areas are extremely important. Let me be a little bit more specific. Say you are an immunologist. At the moment, if you're going to look and understand the realities of differential risk and susceptibility to COVID-19, it's critical to understand the distribution of that risk in the population. So there you bring in the epidemiologists. And then you bring in the systems analysts as well, because you see that young people from racialized communities that are essential workers are the ones that are fueling the third wave. And that then provides you with a much stronger approach to targeting and managing risk than it might if you thought that you didn't have evidence or understanding of those socio-distributional realities. So those are some of the things where I think it's extremely important. Having said that, I get on my high horse a little bit with epidemiologists who sometimes think that, like I did as a clinician, that drugs were delivered from the sky when I needed them, or by a nice drug rep who would give you free lunch. When the reality is that data doesn't fall from the sky. Mm-hmm. And I was quite troubled by the fact that it took WHO, I still don't even think we have an official ICD code for COVID-19 as a cause of death. And it required basically computer scientists, not epidemiologists, to figure out excess mortality associated with COVID-19. Mm-hmm. Whereas an epidemiologist who's been schooled in systems thinking as part of their training will understand that they have a responsibility for how the vital registration and cause of death system works. And if it's not working, if it's not responding quickly enough, if it's not comprehensive, if it's biased, then it needs fixing. And there's no one better to fix it than the depth expert who knows everything about sampling and sampling bias. It's not a systems expert who's going to sell that. It's somebody deeply versed in what constitutes good, reliable, valid data who needs to understand they have to pay some time and attention to the mechanics, the way of generation of data and those systems for generating data. So I think that in addition to having that mix of disciplines, that even within depth disciplines, there's room for improving competencies associated with understanding how systems that are essential for your work have to be understood if you're going to navigate and negotiate those for better performance in the future.
Perfect. Thank you. Thank you very much. So this is a great segue for a question that was asked also by the audience, and it's from Catherine DeVries. she was asking, well, how do we actually close this gap, this divide that exists between the public health and clinicians? I mean, what could be done in that realm? And I would frame it again from your conversation. What is the role of academic health centers in helping with that?
So it's a great question, and I don't think there's a simple answer, but from an academic health center perspective, if you think of where the frontiers of knowledge are perhaps the most exciting, I would make a strong case that the most exciting frontiers of knowledge are on how we unite the opportunity for health on the front lines in the community. And that has a huge role in terms of understanding risks to the public's health and the management of those risks. But it also has huge downstream implications in terms of what the nature and flow of patients are into facilities. So if you can do effective primary prevention or even secondary prevention for NCDs in the community, aided by mHealth, with cadres who understand that somebody broke their hip not because of osteoporosis, but because their banister broke in their house and they didn't have someone to fix it, right? If you have that sort of intelligence, then you can move to a much more rational system of prevention and triage and better not only use of what the system has to offer, but arguably probably better outcomes. Now, the knowledge that's required to do that is not coming out of Harrison's textbook of medicine, with all due respect. It's coming out of understanding context in real time on the front lines. And I think there's a huge convergence there that is of growing interest. Speaking to somebody from the United Health Group recently, and she was saying, just give me any example of innovation on the front lines with patient-facilitated decision-making or new types of cadres. She said, I want to understand it all because it's all hugely important for us. And she said, and this is why I think it's so important, is the biggest driver of her business. United Health Group is a business, okay, in the context of US healthcare. She said there are going to be conditions for delivering more with less into the future. And she said, I want to be on the front edge of that innovation because that's the only way we're going to stay in business. So to me, I think both from a pure knowledge perspective, but also from an imperative to move the yardsticks on how we deliver care and how we keep communities healthy. There's a tremendous and exciting knowledge frontier there, which I think should not only be the responsibility, but I think academic health centers should be at the vanguard of that.
Well, it's really interesting the way you have been answering these questions, because it usually connects with another question that is coming from the audience at this point. And there's from Dr. Watt, Melissa Watt, and she's asking, well, how do we academic health centers contribute with developing capacity in low and middle income countries without falling into the traps of knowledge and capacity that are at the core of the colonialistic approach to education and sharing? And there's a corollary question here. I mean, you presented the global health masters in Rwanda, and it's 55, according to an article in BMG Global Health, it was $54,000. How that figure could be inclusive in a country like Rwanda or in a continent like Africa. So I mean, that's at the core of this. And then it's another point is your experience in Bangladesh. How do you construct that from the non or the colonization in health education?
So all great questions. And I think the issues of understanding what I call implicit values and structures in the way one thinks about education is really important. I was encouraged. I was reading an article recently on colonial and neo-colonial approaches to global health education. I was only encouraged because they identified the recommendations coming out of the Commission on Health Professions for the New Century as the sort of paradigm to decolonize. Now, I have to say, honestly, when we did that commission in 2010, I don't think the word colonial or decolonialization was mentioned once. But I'm saying that because the group that we had, which could have been much more representative, gave what I think were honest intellectual views on what was needed to empower health systems to have agency coming from within, from their own education institutions, that would lead change that's important to improve the performance of their own health system. Now, how that gets implemented is not what gets recommended from Harvard, right? What it does is it requires real leadership of those institutions in the context that they find themselves. And so when you look, for example, in Uganda, what's happened with the College of Health Sciences, led initially by Nelson Sewankambo, he basically had created a new frontier for training, interdisciplinary, interprofessional, well ahead of any recommendations from a commission, but based on what he and a set of people in Uganda felt was the direction that was needed. So to me, I think that leadership is the most important part, which is there's no prescription from outside. You have to create leadership internally and generate consensus on what is needed to address health professional training in specific contexts. But let me also not be naive on that front. A lot of what you have in educational systems related to health professionals is rot, which are institutional bureaucracies that are parasites rather than proactive. And they feed off systems of monopolistic rent, to use an economics term, whereby because everybody has to go through them to get accreditation, or to be deemed legitimate, or to get a license, or to be given permission to move forward, or to continue, and then all of the wrong reasons creep into those negotiations as opposed to the ones that can be justified on transparent grounds that any public could analyze. And if you can purchase your way into this business with no accountability, then whether you call that colonial or decolonial or post-colonial doesn't make any difference. It's rotten. There's no place for it. But if what you can say is you're making changes, and here's the template against which we're making the changes, this is the rationale, this was the process of consultation, and this is why we think it's a step forward, then that's transparent and you can be held to account. And if that's done with local leadership, then that, to me, is the way forward. The other part of this is that if we're honest about learning, we're idiots if we think we can't learn from the global resource that we have. And so my, sort of simplistic way of viewing this, if you can sample from 7.5 billion, why would you be content with a sample of 350 million? Right? You have at least 20 times that power, 25 times that power with a larger number. And if you think of what the groups that constitute the population of the United States of America, their diasporic origins are anything but homogenous. And so understanding and embracing that global diversity, I think, is absolutely imperative for our survival and our well-being as a human race. And so we're at an age and stage where working with the global commons, the global knowledge commons, and recognizing that there's valuable knowledge that can be generated anywhere, that has relevance everywhere, is, I think, the way forward. So I don't apologize at all for global health. I think we need to absolutely embrace it, but embrace it in a way where we empower that generation of local knowledge and we share it with a view to understanding how we can all do better in our own respective backyards. In terms of fees of some institutions, I think this is something that really is, that should be made more public and asking real questions about it. I was always very proud that our MPH 1-year residential in Bangladesh costs the equivalent of about $5,000 per student. And you contrast that to $55,000 and you say, well, woof, how's that possible? And so I do think that one should challenge the models because they become de facto exclusionary. But it's not just economic access, it's gender access, it's racial access, it's a whole set of diversity criteria that we need to be much more sensitive to in optimizing student intake and enrollment. And those should be where we should be thinking not only about our enrollment criteria, but also whether post-secondary institutions are generating students that are able and willing and interested in moving into university environments. In my own country, Canada, we're very concerned about Indigenous people's access to public health training, yet the primary bottleneck is that not nearly enough Indigenous young people are making it out of high school. Dropout rates are horrendous. And so as an academic institution and interested in righting that imbalance, we need to be vocal with respect to the failure of secondary education and be part of solutions that help mentor students and support them through to graduate from high school. Because if we don't increase that pool, then we'll be continuing to have imbalances in terms of eligibles for admissions to the programs where we'd like to see more diversity. So I think we have to actively be active on all of those dimensions of inequality, financial, racial, gender, that are part of what manifests itself in our higher education institutions.
Thank you very much. I think we still have time for a couple of questions more. Dr. Tan, Dr. Raun?
I think we can ask one more question, and we also wanted to send out a feedback link, so we'll throw that in the chat for y'all to take a look at. Perfect.
So the next question, Tim, departs a bit from our conversation, but it's a very practical one. How do we incorporate community health workers into the healthcare system? How do we legitimize them and pay for their contributions the way we should? I mean, this is a question from Sharon Talboys from the Public Health Program Division at the University of Utah.
That's a great question, and part of it is and perhaps Juan Carlos, you'll like this, but is having a much more pluralistic model of professionalism with respect to health professionals. And I say that because old school professionals get very turfy. They protect their guild and they feel that somehow that change is a threat to their survival. And therefore they become the barrier rather than the facilitator. But I think if you say that our current models of care are falling short significantly, particularly on the front lines, that interaction with communities and that continuity dimension and that understanding context, that, as I said earlier, that it's the banister that's broken, not osteoporosis that is responsible for the broken hip, then legitimacy of the role that other individuals who are trained perhaps as professional context agents, who have a regular role in understanding how individuals are doing, which would never be facilitated in the context of a clinical interaction, either virtually or in an office, because of time constraint, then one can open up the space for these people. Second is, I think one should be thinking about the career timeline for professionals. And we have a model here at the moment which is heavily skewed to pre-service, meaning you train in undergraduate, postgraduate, residencies, fellowship training, and you're bald, as I was, before you actually did any real work. And many people feel that there's so many hurdles now that have to be surmounted prior to practice, that they lose appetite for education. Rather than saying, actually, why don't we change the model a little bit and have people go back and forth over time? And as you get experience, work in some way, and perhaps start in a more junior level cadre, but get that experience, that knowledge, and then draw on that to direct your clinical specialization. And so you think about the career course, not as continuing medical education, but as a continuing education opportunity to develop your professional skills and abilities. And I think if we thought about that on the academic health center perspective, the business model on that is actually quite interesting, because as people move forward in their careers, their ability to pay and their ability to learn and draw on their experience changes. And so the model moves from being 4 years or 8 years of full-time in the grinder, perhaps to something which is more modular and periodic and has a lot more executive qualities. So I'm just saying that those are some of the ways that I think we can make space in our model of human resource professionals. In addition to getting over the fact that somehow, if you don't know as much as I do, somehow you're not fit for the system. The task shifting evidence that's come out in the context initially of scaling up HIV and access to antiretrovirals in Africa, I think is very promising on that front. A recent report from McKinsey, actually, their global analysis, or whatever they call that institute, the Global Institute, identified midwives as one of the best investments for middle income countries in terms of improving performance of their health system. So I think some evidence of their value, plus some change in attitude, and recognizing that that the more plurality we have, the greater likelihood we're going to be able to manage higher performance, and perhaps also a number of things like burnout as well.
Well, thank you very much. It has been wonderful to listen to you, and the experiences, the breadth of knowledge is both refreshing and remarkable. Thank you very much.
Yes, thank you.
Great. Well, I assume most people are asleep. So if you ring a bell now, you can say, time to wake up. It was all a bad dream.
No, it was full of excellent content and food for thought, and things that we can really be introspective about going forward as an institution. And we appreciate everyone's time. We have lots of thank yous coming in through the chat. So we appreciate everyone's time for being here and listening and being so interactive. For the questions that didn't get answered, I've saved them, and we'll try to get those answers to you. And then we have a session after this. Otherwise, our next Audience session will be tomorrow afternoon. So thank you, Dr. Evans, for being here.